And education about pain is powerful. Research has shown that. Just explaining to people what pain is.
And it normally lowers pain?
And just educating people about it.
Yeah.
If you say, hey, I know that you hurt yourself, tell people about the studies, people, or hey, I'm in all this pain, I just got this MRI, it shows all this bad stuff, and then I go through that story about showing how MRIs, you can have these things and you can not have pain. We can get you, even if you've got this stuff on your MRI, in an out of pain state. Talking about that pain isn't necessarily bad. You're not doing more damage by moving through pain. It's okay to move through pain. All those things kind of just calms people down a little bit, so that they're not as focused on the pain. And once you kind of show them that they can move through it, and it's okay to move through it, it's not going to make it worse. It's not doing more damage.
It's not going to kill them.
That all desensitizes the nervous system, bringing pain down.
What's going on, bud?
Happy to be here.
Yeah, thanks for coming on. Okay, so if you want to do me a favor, so that way everybody knows, if you want to give name, what your work is, what you do, just the simple stuff right off the top.
Yep. I'm Dr. Michael Price, physical therapist. So I moved to the Valley about 8 years ago from Wisconsin after I finished my doctorate up there to do an orthopedic residency here. That's what brought me to the Valley, and now I've been practicing physical therapy for 8 years here and opened my own practice 4 years ago, modern movement physical therapy. And have had an opportunity to treat and meet so many amazing people throughout the Valley in the last 8 years. And let's see here, married, got a little boy at home, and
another one on the way?
And another one on the way, yeah, man.
That's awesome. So were you doing this same thing before you came out here? Some like different places?
Nope, so finished up my schooling in Wisconsin, moved down here to do the residency, and started practicing at that same time. And so I started working for a larger corporate physical therapy company for the first 4 years, and then had the itch to open my own practice and do that. So now I've been doing that for 4 years.
Okay, so I'm gonna say this. I put up on my social media, I asked these series of questions, right? Do you know what I was asked by honest God, it was 30 different people? How come some people are a doctor and some people aren't in chiropractic work?
So a doctor of chiropractic it's a clinical doctorate.
Okay.
Physical therapy is a clinical doctorate.
Okay.
There is not a program in the country that doesn't exist anymore that is not a clinical doctorate. There was a movement in the physical therapy industry where in 2000, about 14 or 15, they transitioned all physical therapy programs from what was a master's degree to a doctorate program. So it used to be a 2-year master's degree, and now they moved them all to a 3-year doctorate. The reason they did that is they wanted to establish direct access to physical therapy. Before, you had to see a physician, get a referral.
And they would send you over.
And then you could go see a physical therapist.
Okay.
Now that they made it a doctorate, now that we can be the first provider that you see.
Yeah.
So that's important that it was a doctorate because they needed to ramp up the curriculum so that we were, able to screen for all kinds of different things, whether it's, musculoskeletal or potentially neurological, cardiovascular, pulmonary, things like that. So we're qualified to see patients first.
And then when you go in, obviously you have other people that are training or doing a residency or doing something because they're not doctors, but you go and see them at a clinical place, right?
You saying like a traditional physical therapy clinic?
Yeah.
So you always see your physical therapist,
Okay.
but then a lot of times the way those corporate models are run or the insurance models is you see your physical therapist for a few minutes. It might be 5, 10, 15 minutes, and then they pass you off to a physical therapy technician or a physical therapy assistant, which is another degree.
Got it.
And they will take you through, maybe an exercise program, something like that the physical therapist, the doctor of physical therapy prescribes.
And that's kind of like normal big box system of how those work.
Correct.
Cool.
That's not how I work.
Not how you work.
No.
So you diagnose a symptom or diagnose whatever the problem is. You do the protocols all the way through to the end.
I see the patient from the time they walk in to the time they're out. They're with me one-on-one the entire appointment.
Got it. Okay.
So I don't use technicians. I don't use assistants. It's just me. And so yeah, a doctor of chiropractic, doctor of physical therapy, a dentist is clinical doctorates. An MD is a medical doctor, so they went to medical school to become an MD. A PhD is an educational doctor. So that means you can get a PhD in virtually anything.
Anything you want, yeah.
You can be a PhD in music or a PhD in almost anything.
Yeah,
It's
yeah,
an
yeah.
educational doctorate.
Okay, so then getting into the actual nerdy part of it.
Mm-hmm.
One of the other things that I'm always interested in is, we kind of briefly talked about this before, was central nervous system, right? How activated it is during the day because of pain or because of other things that you have going on. How often do you see it that people maybe are in so much pain that then they're in this flight or fight response all the time, and so it's messing them up? Let's say not just neurologically isn't the word that I'm looking for, maybe like emotionally or something, or they're kind of like so fired up about everything else that the rest of their bodies seem stressed out.
Yeah, pain's tough. Everybody handles it differently. Pain is incredibly wearing, especially if you have it constant, meaning all the time, every day. And then if you look at chronicity to how long someone's in it for. So if you've got something that happens, you hurt your back, you've acute low back pain, and you deal with it for a week, and you're getting through it, you're managing it. But let's say it doesn't go away.
Okay.
And now 2 weeks you're dealing with the same back pain, and now 3 weeks you're dealing with the same back pain. First few weeks you manage it okay because you hurt yourself, you got some pain, you're hoping it's going to go away. But when that pain doesn't go away, and now it's 3 weeks to 3 months, now you're dealing with this pain constantly. That is incredibly wearing.
Yeah.
So that makes the nervous system become heightened, makes all other things heightened in the nervous system, and that can just spiral out of control.
So do you find that people normally, or do you find a lot of people will come see you after they've been in pain for months and months? Or are people pretty good about coming in once something is painful?
People are pretty good about coming in as soon as something happens. I encourage people that when something happens, give it, a couple days. If it's just a strain or, a kind of an overuse injury where you did a little too much, too quick, too fast type of thing, give it a week, do the old rest it, ice it,
normal stuff.
The normal stuff. See if it can calm down on its own first.
Okay.
Our body is incredible at healing itself in many cases, in most cases. But every now and then, after a week or two, if it doesn't go away, I encourage people to get their butt in to come and see me, and people are usually pretty good about doing that.
So what is the most common injury or pain situation that you find that people are in that gets like mistreated or not treated, do you know what I mean? Where they're just dealing with it for way too long?
I see about 40% spine-related pain or injuries. So neck pain or mid or low back pain is about 40% of the patients that I see. And I would say most people with low back pain think the worst. They think they immediately need to go and get X-ray, MRI, need to get on medication, think that their pain is so severe that something really bad has to be going on and that they need to have surgery and they need to diagnose and find out exactly what's going on. And that is the most common, not necessarily mistake, but this is the wrong mindset that most people have in regards to those injuries. Most really bad neck or low back pain, because I've done it myself, can get better either on its own or with just the right treatment, corrective exercises. Maybe some mobilization or manipulation of the spine. Maybe it's some deep soft tissue work and release with dry needling or things like that. But almost the majority of low back and neck pain does not need the imaging and does not need surgery by any means.
This is incredible that you would say this. This is a real story. This is about me, right? So have always lifted heavy, very into athletic training, but whatever. Consistently from 25 to right now, I'm 38, always had some kind of lower back pain, but it goes away and then it comes back again on and off, whatever. Mm-hmm. So recently, this is within the last 3 months, I went into a place. Mm-hmm. They had me do a X-ray,
Okay.
said that I have a compressed lower disc spine, or lower disc, something like that. I don't remember.
Okay.
Were concerned that it was a bulging disc, that something was actually like really
Yeah.
bad, and told me I needed to go get an MRI. So they did. They got me an X-ray, told me I needed to go get an MRI.
Yep.
But then I kind of asked them, I was like, well, if I go get an MRI and I do all this, what is the next step? And then it did kind of seem like it was like, well, we can do like spinal decompression, so I was like, so does it matter for me to go get this stuff? Like,
Yeah.
is it, you know what I mean? It just seems like...
Why? What's the point of doing the imaging then? 'Cause
Yeah.
you're just going to go do those things first.
It's like, well, can we just do that today? And they're like, well, let's get the MRI first.
Yeah.
And I ended up not getting the MRI.
Okay.
I didn't go. And then I'm like, well, I need to do something. So I kind of, it's just funny, this exact scenario that you're talking about. Because it does hurt. There are some times where it hurts. Analogy again is I went and got a tattoo yesterday, real long one. So I'm sitting in this weird, awkward posture for 8 hours.
Oh, yeah.
Well, it already hurts anyway. And so today I'm on fire.
Okay.
But then other days come where you give it, you know what I mean? A couple days and it's okay. I can kind of do stuff.
Sure.
So what is somebody like me, what do I do?
Well, so, I mean, first steps, you got to come see me, right?
Look at this guy.
Come see me.
Look at this guy.
First of all, right?
Yeah.
I'll run you through a thorough evaluation. I know you've had, the X-ray. The X-ray showed, maybe some degenerative changes, maybe a little bit of compression on a disc. Mm-hmm. That's not the end of the world. There are, and I'll get into that in a second. But evaluate it, see exactly what's going on. That will, allow me to identify where we need to direct treatment, what's the most appropriate treatment, and then pair it with what's going on with you.
Okay.
And so, if you've got some compression on compression of a disc, maybe some compression on a nerve root, we need to see if we can mobilize around the nerve root, decompress that nerve root. That can be either with mobilizations or manipulations from me, show you some movements or corrective exercises that you can do to replicate that. Maybe it's some, dry needling to release some deep musculature that's down around that nerve root. And then do that, a couple times a week or once a week for the next few weeks, see if we can make a change. Mm-hmm. And that's where we go from there. So
it's, I think that a common thing is, and I'm speaking for kind of everybody in general, right?
Yeah.
It's like you go into one chiropractic office and they say something different than what kind of says in the other one. And so it's not like it's bad or something, but I think as the consumer, sometimes we're like, well, what do I do? Do you know what I mean?
Yeah.
But I guess it's no different than medical doctors, though. You go into one, and so you just don't really know what to do.
No, it can be frustrating going to one person, getting a different answer, and seeing someone else and them telling you something else.
Because even the process, like what you're saying, is literally the exact opposite of what this other place said to do. They're like, well, let's not do anything. Let's wait and get this and this. And I remember I'm looking at that thing on my spine, and the way they're explaining it, I'm like, oh, I'm not gonna be able to walk.
Yeah, so that's what I wanted to get into. So they've done, we've done, when I say we, I didn't do it. The orthopedic and sports medicine world has done some huge, robust studies where they gave 1,000 people an MRI of their low back. They did one for the cervical spine and the neck as well. And the criteria is you had to have no low back pain at all. So 1,000 people from age 30 to 70 with no low back pain, and they gave everybody an MRI, and they wanted to see what kind of findings were on that MRI with people with no low back pain.
Yeah.
We already kind of knew what the findings were going to be, but we wanted to just do the study to prove it, and it followed it almost by decade. 30% of 30-year-olds, 40% of 40-year-olds, all the way up to 70% of 70-year-olds had one of four things: mild to moderate facet arthropathy.
What is that first one?
Facet arthropathy. It's inflammation of the facet joints of the spine. It's where the spine, each vertebrae as they stack on top of each other, connect. Okay. And so you have a joint on each side of your spine at every vertebral level.
Okay.
So it's the joints of the spine, the facets. So arthropathy meaning inflammation or irritation of the facet joints. Okay. Mild to moderate facet arthropathy. Mild to moderate stenosis, meaning narrowing of the hole where the nerve roots come out at every vertebral level. If that hole narrows, it can put compression on that nerve root. Okay. So mild to moderate stenosis, mild to moderate degenerative disc disease. So that's what they said with you, with compression of the disc. Okay. So that's degenerative. They call it disc disease, but at the end of the day, it's Well, let me get to the fourth one.
Yeah,
The fourth one, bulging or herniated discs.
Okay.
So you've got 40% of 40-year-olds have those things on their spine with no low back pain.
Yeah.
So what does that mean? That means basically that just because you have those findings on your MRI does not mean you have to have pain. Also means that basically this shows that if 70% of 70-year-olds have it, it's the normal progression of
shit gets old and shitty and it wears
degeneration.
out.
It's the normal progression of your spine through time and through age.
But that doesn't make it a bad thing.
Well, no, because you can have no pain, no back pain, and have those things. So that's why the MRI, you can't, if I go and get an MRI, I have no back pain. But if I go an MRI, I know that there's going to be some stuff. There's going to be some shit on that MRI. There's going to be some findings there, but it doesn't mean you should freak out and say, oh my gosh, I need to have surgery, or I shouldn't move. My spine's got all this stuff. What does that mean? It means that you don't have to have pain. Now, when someone does have pain, okay, and you go and get an MRI, you want to pair, okay, he's got pain, he's got this rap sheet of all this stuff on the MRI. One of these things is probably producing some pain, right? But that doesn't mean you need to run and have surgery, because all those people have those things and were able to get to a point that are pain-free. Maybe they did have pain at some point, but they did some physical therapy, or they did the right corrective exercises, or they removed something that was an irritating behavior, or maybe they got crappy posture, or maybe they were squatting with bad form, or they were doing something that was irritating their pain. They removed that, and now they're in a pain-free state. Maybe they started doing more core exercises to get their spine more stable. Maybe they got a standing desk to not sit in crappy postures much throughout the day, and so they had something that was causing them pain, and they changed it. But their MRI is going to be the exact same from when they were in the pain state to when they're now in a pain-free state.
Got it.
I know that was a lot.
No, but it actually does make sense. And if you think about it, I guess and you don't want to call anybody a bad guy or something. What they're doing is they have the ability to show something that says like, hey, you need to go do now X, Y, Z, even though that may not be directly correlated, right? Like being able to show the X-ray or MRI.
Yeah.
I know that in my head, the first thing I thought, because I looked at it, and granted, I don't know what a good or bad spine looks like anyway.
Yeah.
But it did look, I was like, oh yeah, there's less space in between those ones at the bottom.
Yeah.
And mine does hurt.
Yeah.
So I guess sign me up for whatever I need.
Well, but so if you can, like you said, so I tell people, if you go and get an MRI, and if we're talking about surgery, if I tell people to have surgery when you've tried everything else, when you've tried the physical therapy, you've given it a real fair shot, or you've done corrective exercises and stretches, and you've done it consistently, you've done it for a while, and it didn't work. You've tried all the things, and you are still miserable. Your pain is affecting your quality of life. It is affecting the things that you want to do or you can't do because of it. Fine. If surgery is appropriate, then you've tried all the things, then you can go and have surgery, if that's appropriate, when you've tried all the other things.
Yeah.
But until then, the MRI, unless you're going to have surgery, it's just not appropriate to do right away before you can try some other things. Now, we like to do it, or some physicians like to do it to rule out really bad stuff. Yeah. That's really the point of doing the X-ray and the MRI, is just to make sure.
In case there is something that does stand out that's really bad.
Yeah. Cancer, typically, if you have a really, really bad herniated disc, you don't need an MRI to tell you. I mean, the symptom presentation is pretty clear when someone has a severe herniated disc where that nucleus material of the disc is out, putting pressure on the nerve root. I mean, it can hardly move. But I don't need an MRI to tell me that.
Yeah, I guess the sub side of that is like, because sometimes, I'll try to move and I'm like, oh, I can't bend over, I can't walk, right? So then in my head, I'm like, well, am I just being a pussy? Or do I need to, do you know what I mean?
Yeah.
Sometimes I actually don't psychologically know. I'm like, oh, is this what other people think like would be not too bad? And I'm just a wuss about it. But then sometimes when I'm in the pain, I'm like, oh no, I can't breathe, this hurts so bad. Yeah. So then I don't know. I am kind of like at this weird toss-up because how do you subjectively measure the pain threshold?
Yeah, I mean, it's different for everybody, but I mean, if you're in severe pain, you're probably in severe pain, and you know, and you've tried a bunch of other things, right?
Yeah.
Yeah.
Yeah. I always think that it could, and you know, I asked this also because I have a friend who had this too. He had a serious issue like in his neck. And it's like, yeah, we've gone and done stuff, but have we ever really sat down with like one process to try to heal it for 6 months to a year? Do you know? No, probably not to that extent. Do you know what I mean?
Yeah.
It's always like you can take care of something, and I feel like maybe take some time off working out, get into just walking, maybe some light stretching and things like that. And it's like, yeah, after 2 or 3 weeks, I kind of feel better, and then I just go back to being a bozo again.
Okay.
So you know what I mean? That's just kind of getting back into our normal patterns.
Okay.
And I think a lot of people are like that too. You know, it's hard to really get out of your groove of like, well, this is what I've done for 20 years is lift weights in the morning like this. You know what I mean?
Yeah. Yeah. So some behaviors need to change.
Yeah, okay. All right. Well, that's the answer.
Yeah. We need to, you know, if you're lifting first thing in the morning when you're stiff and you're cold, you need to physically warm stuff up. You know, whether that's getting into the gym a few minutes earlier than you normally would and getting so many steps in, or, you know,
whatever the thing
walk,
is.
get down on the floor and do some mobility work. You know, get on a piece of cardio equipment and actually physically warm up the muscles in the body and work up just a little bit of a sweat, then go load the spine, or then go load with, you know, with resistance. But there's a reason we, you know, want to warm up, you know, the body before exercise, and there's a reason it feels better warm than it does cold, is because your tissue physically takes on resistance and load better when it's warm than when it's cold.
Yeah, warm rubber band, cold rubber band kind of thing.
Yeah.
Okay, let's go to the next. I feel like we're talking about me a bunch, but I want to ask about this then. I think pain in general is a big thing. So, and the reason why I think it's a big thing is because there is stuff that we can take to mask it. There are over-the-counter drugs and illegal drugs and all kinds of other things that we can do. So, is this a big serious issue for people in the United States in general? You like getting out of pain by taking medication and stuff. Is that a big problem, or do you think it's not as big of a deal as what I'm kind of making it?
I think it's a problem. I will say in the physical therapy world, I don't see the pain medication in my profession as a huge issue, or I don't come across it a lot. Have I seen it? Absolutely. I've had some patients that have had some procedures that were prescribed them, then saw me for physical therapy and had a hard time getting off of them, type of thing.
Yep.
But it doesn't happen in my profession maybe as much as it does in the medical world.
Okay.
Does that make sense?
Yeah, no, it does. Because maybe they're going to see a chiropractor, going to go see someone, they're going to go work through movement and take action on it.
Yeah.
Yeah.
Yeah. So, pain, like we talked about, is a subjective thing, meaning it is 100% a perception of the brain. In general, people don't understand pain. It doesn't always mean that there's tissue damage. It can mean that there's tissue damage, but it doesn't mean pain doesn't necessarily have to, you know, be thought about as a really bad thing. You don't have to necessarily always avoid pain. It's okay sometimes to work through some pain, and there's times when you shouldn't. But that's what coming to see, someone like me or a provider like me can help guide someone when you do the evaluation and figure out what's the source of the pain, what's causing the pain, is this pain that is okay to move through or not. But most people think of it as pain is bad, I shouldn't move when I'm in pain, try to avoid it. The knee-jerk reaction is to take something for pain instead of thinking of it as, hey, let's move and let's tell the body that it's okay to move, that this pain isn't a big deal, and that we can move through it and try to desensitize the nervous system. Does that make sense?
It does. This reminds me, I one time did have somebody explain to me about stretching and about how stretching is first kind of like a neurological response of you're not used to that pain of stretching. Not that your body couldn't do it, but your mind and body are kind of trying to keep you to resist from causing injury. So mostly with just a couple of days of deeper, longer stretching, you can increase your mobility by a lot, because it's not that your muscles are stiff and won't do it. It's that like your brain is saying, oh, that's pain I don't want to touch.
Yeah.
Was how it was kind of explained to me.
Pain is 100% a perception of the brain. So we got inputs that come up to the brain, and our brain gets to decide if it wants the output to be pain. Okay? And that is, to everyone, a lovely scale of 0 to 10 pain that everyone's been asked. Your 8 out of 10 pain might be someone else's 3 out of 10 pain. Yep. And that's just, everyone's perception is different.
Yeah.
And for different reasons. And your perceptions can change based on the irritability of your nervous system.
It says like, how bad is that pain, right?
Okay.
And I give them a rating. I say, this is bad. You're right. This is an
Yeah.
8 out of 10 or something. Is there anything else that you can do to rate pain? I mean, wouldn't there, if you're talking about stretching or something, maybe how far you can actually stretch, some kind of objective measure?
There is no objective measure of pain. There's nothing that we can measure in the body. There's no chemical that is pain. There's nothing that we can, all we can do is, if with imaging, we can see tissue damage, right? But as we talked about earlier, tissue damage doesn't necessarily correlate to pain.
Yeah.
You can have someone that has an MRI that has pretty clean MRI in a ton of pain, and you can have someone that's got a whole bunch of stuff. It happens all the time. I'll have someone walk into my office, sit on my table, that's got a severe bulging disc, and I know they're in pain. I can see the way they're moving, and I ask them how much pain they're in. They're like, yeah, it's a good 4 or 5. And I can have someone that just pulled a muscle. And I'm not saying pull muscles don't feel good. They hurt, I get it. But they'll say, yeah, I'm in a 9 out of 10 pain. And it's like, you just walked in under your own power.
Yeah. That's not a 9.
You're kind of smiling, having a conversation with me, and you say you're in a 9 out of 10 pain. That just doesn't match, right?
Yeah.
But there's nothing that we can measure to get an objective measure of pain. That's why pain is a fascinating topic.
But it is kind of funny to me, you saying that. It's almost though, it's like you as a doctor, you can say, well, I know it's not a 9 out of 10, because a 10 out of 10 would be your arms are blown off.
Take me to the emergency
room.
Yeah,
you know what I mean?
Yeah.
So this isn't a 9 because we're talking about what you did yesterday.
Yeah.
This is maybe a 5. I'm not saying it doesn't hurt.
Yeah.
But of your max capacity of a 10, it clearly is not on that edge of it.
So that's where you want to educate people about pain and have them understand that.
Okay.
And education about pain is powerful. Research has shown that. Just explaining to people what pain is.
And it normally lowers pain?
Just educating people about it.
Yeah.
If you say, hey, I know that you hurt yourself, tell people about the studies, people, or hey, I'm in all this pain, I just got this MRI, it shows all this bad stuff, and then I go through that story about showing how MRIs, you can have these things and you can not have pain. We can get you, even if you've got this stuff on your MRI, in an out of pain state. Talking about that pain isn't necessarily bad. You're not doing more damage by moving through pain. It's okay to move through pain. All those things kind of just calms people down a little bit, so that they're not as focused on the pain. And once you kind of show them that they can move through it, and it's okay to move through it, it's not going to make it worse. It's not doing more damage.
It's not going to kill them.
That all desensitizes the nervous system, bringing pain down.
So that is kind of funny. It does seem like a lot of your job is, part of it is the physical part of it, but part of it is also working with that patient and helping them through the psychological parameter of it. Do you know what I mean? Like, how do they feel about it? Are they upset about it? Do you know what I mean? Like, that seems like a big part. You're a therapist as well.
Oh, absolutely. I mean, education is, and talking with my patients is an equally as big part of the physical treatments that I do. Mm-hmm. Educating people about what's going on, what's their injury, what's the prognosis, what do we need to do to treat it, how is that physiologically going to work, and just explaining to them what's going on and how we're going to do it is half the treatment in itself.
Absolutely.
Because most people, whether it's a medical issue or a musculoskeletal issue, there's just a lot of times that people go to see a provider and it's so quick and they don't get the thorough sit-down explanation. This is what's going on. This is what we're going to do. This is how we're going to do it. This is how you're going to respond to it, and give them that roadmap and let them ask questions, get those questions answered. So many times people are left with, questions after provider leaves or after the treatment. And so it's always my my priority to make sure that they are educated about what's going on, what we're going to do, and how I can help.
Yeah, it is just a different perspective about being, there as a therapist for them too. But really, we talk about that a lot, even for medical doctors, is like the bedside manner stuff, right? That is a huge portion of it, which does seem, in my eyes, to get worse over time. As I did read about this is medical doctors, so I don't know about your field of law, but these doctors being bought up by investment firms. And so the doctor is basically squeezed to have 3 or 4 minutes with every patient to maximize how many patients they see, to maximize profitability. But then the patient feels, completely left in the dark about what they're doing.
Yeah.
So it doesn't make anything better for anybody.
No, it doesn't. And that's the frustrating thing about our medical system, about our insurance system. That's why I left what I was doing in the corporate physical therapy world and started my own practice, is I wanted more time with my clients. And I felt that when I was in that other setting, I was scheduled a patient every 15 minutes for an hour. And so, by the time a patient sits down and you ask them, all right, how are you doing? How have you been doing since the last session? Give me an update. Okay, 5 minutes are gone.
Yeah.
Okay, now we got 10 more minutes to do,
the work,
whether that's treatment. And if you want to make true tissue change or true mobility change, you can't do it in 10 minutes. I mean, sure, you can do a couple needles, and maybe you can get a trigger point to release, and maybe you can do a spinal manipulation or adjustment. But I have found, and research has shown, that if you want to make true tissue change, after you do that dry needling or after you do that manipulation, if you follow that up with more soft tissue work and more mobilization and stretching and things like that, you make the results from those other treatments last, and you make them more effective to make true tissue change.
Yeah.
You need more time than 10 minutes. So I don't take insurance anymore, because that's why we're scheduled a patient every 15 minutes, is reimbursement rates are coming down. That's not just the physical therapy world, that's dental world, that's medical practice. So you want to try to see as many patients as you can, bill as much as you can, because reimbursement rates are coming down. So when I got into practice,
why are reimbursement rates coming down? Just the economic force of...
It's a good question. Why are insurance companies paying less for services? I think a part of that is the way things are being billed. It's kind of a vicious circle. Whether, let's just say the physical therapy world, we'll go there. To try to optimize billing, we're trying to throw as many billing units as possible on a physical therapy, as ethically as you can and legally as you can. Try to throw as many billable units on an appointment as possible. If you can bill a bigger appointment, let's say you send a bill to insurance for even numbers, let's say $100, okay? Reimbursement rates used to be 85%, so you'd get $85 of the 100, okay? Well, if you can get that bill to be $200, $300, you're obviously going to be reimbursed a bigger number, right? Well, insurance companies are like not liking that these, whether it's physical therapy or medical, is racking up these big bills, so they got to pay more. So what they do is they reduce the reimbursement rate. Okay, if you're going to throw me a $300 bill instead of something that's really supposed to be $100, instead of 85%, I'm going to give you 55%. So reimbursement rates are coming up. PTs are still trying to keep bill a high appointment, and then we're trying to see as many patients as possible. Does that make sense?
No, it does make sense. But from the consumer's point of view, they've bought into an insurance plan under the guise that, they're going to be able to, this doctor's in network, so I'm going to be able to go in and I'm going to be able to use this from the insurance that I'm already paying this bucket into.
Yeah.
That doesn't seem legal even to me to, on the back end, change the way that the insurance company is working with the doctor. Because then the end and net effect is you guys end up changing your price, or if you carry insurance or whatever, which affects the consumer. It seems like, I'm trying to get an analogy here, but like if you make a car and you say it's made of XYZ material and the first couple are, but then you go to the manufacturer and change it to a lower class material, just because the first one, that's what you're selling me.
Yeah.
Do you know what I mean?
Yeah.
That actually seems illegal.
Yeah.
Because now you're even though at the front to the consumer it doesn't seem different. Well, it does when doctors start going out of network, or they start changing their prices on things, or the services they offer.
Yeah.
That doesn't, that seems illegal to me.
Yeah. So it was frustrating. That's why I didn't want to practice in that setting. That's still going on now. That's your typical insurance-based corporate physical therapy company. That's how you're rolling. That's why your doctor's appointments are less than 5 minutes. When you go in there, you see the doc, and then he's out. He's on to the next one. So I don't take insurance up front. I'm a cash-based model.
And I think a lot of them are now.
Even medical doctors are doing that.
I know.
It's kind of that concierge type model is the word that's being used. And so it's you got your time with me. I see my patients for 45 or 60 minutes for an appointment. We got time to make the tissue change that we need to do to have all questions answered, and I bill a price for that. Now, what patients can do, and a lot of my clients do, is they can still submit to insurance and get reimbursement at an out-of-network rate.
Yeah.
So you're still getting a good chunk back.
Yeah.
But I'm just not messing with the insurance up front. I'm not having them dictate how I practice.
Yeah.
I want complete autonomy with the way that I practice, and I'm not going to have an insurance company dictate that.
No,
So
I agree.
I charge this, you pay me this, you go and get reimbursement from the insurance company.
That entire system to me is just wild. And it seems like everybody knows that it's not right.
Yeah.
But we all just kind of have our hands up like,
Yeah.
It's
frustrating.
Well, what are you going to do? What is the move there to get rid of it?
Yeah.
You never know. All right. Well, hey, I appreciate you taking the time to come on here.
Yep.
All right, guys, that was Rituals with the Viking. Thank you so much for listening. If you like that or know somebody else who would like it, please share it with them. Go right ahead.
Good chatting with you, man. It was good to be here. Dr. Michael Price, Modern Movement Physical Therapy. I'm located up on East Bell Road in Northeast Scottsdale. You can find me on Instagram. I got a website. And you can book appointments right online. I offer a free 15-minute consult that you can book right online and come see me and just kind of get to know me and ask some questions. Or we can book a phone call and we can just chat on the phone. But
What is the website?
mymodernmovement.com.
My Modern Movement. And is your Instagram handle the same?
Modern Movement PT.
Modern Movement PT. Awesome. Thank you for coming on, brother.
Yeah, man. Happy to be here.
Dude, thanks, man.
Thanks.
Appreciate it. We did it.